going to move to our next speaker, Dr. Jimenez-Franco from Monterrey, Mexico. His talk is Challenges Faced Starting a Cardiogenic Shock Program. We are reminded, thank you for coming all the way, and we are reminded of one of our godfathers, Eugene Brownwell, and his lines, how many things he was learning every time he was visiting Mexico and the hospitals there. Please share with us.
Thank you very much for this kind invitation. I'm really honored to be here and presenting some of the challenges. I think if we ask individually to different programs here, everyone has faced different challenges. So today I'm going to present to you what has been some of the challenges in Mexico. I have no disclosures for this talk. So I would like to start by just saying that building a cardiogenic shock program is like building a house. At first, it's just a foundation. But if you bring the right blueprint, which are the protocols, and the equipment, which are the devices, the vasoactives, and the equipment, but most important, I think, you have to create a solid team. And this solid team includes interventionalists, heart failure specialists, nurses, cardiac surgeons. And then once you build a house, then you can move in and start living comfortably. And this is when you start improving patient outcomes. And it's relevant because we all know cardiogenic shock represents a significant group of patients, and the mortality remains high despite different advances and support devices that have been developed over the years. I just want to create a context of what we are. We have a hospital called Hospital San Manuelian that it's located in Monterrey, Mexico. Monterrey is at the north part of Mexico. This is a private hospital, a private institution that belongs to a University of Tecnológico de Monterrey. So the first challenge was to identify our shock team or the core team. And this was very relevant, and if you see this list, but most important was to identify what were the specific roles that each one of the members has in this team. And if you see at the bottom part, we included the administration or the service line in this part of the shock team because they actually facilitate us during the process of developing this program. Another challenge, as has been mentioned before, the financial and logistical challenges. You know, we all know that these devices are expensive, and in Latin America, this can be an issue. Not everyone has medical insurance that can cover for these devices. At the beginning, there was a lack of infrastructure. Who's going to take care of these devices? Who's going to supervise this patient and limit the vascular complication? There was a limited trained personnel regarding the use of these devices or protocols in cardiogenic shock, and there were some ethical and social challenges too. Another challenge was at the beginning to educate people, to educate about cardiogenic shock, about the benefits of the early diagnosis and early identification of shock, about the new data and protocols, algorithms. We had the honor to have lectures from experts in the field to our institution, and this was wonderful. These were lectures given to fellows, to trainees, to cardiologists, etc. Then we built a protocol. So the protocols were already published. So what we did was we adapted these protocols to the capabilities of our center. We don't have all the devices, but this was a good start. So then we set the code shock. The activation of the shock team, because now you have the team, you have devices, you have trained people, but you need to go for the patients, and the patient do not come directly to the shock team. So we established the shock code, and this is an image that is in Spanish, but it's about how to activate and who is the shock team and when to activate. And this is placed in different critical areas of our hospital. Some of the equipment and technological challenges, as I already mentioned, we don't have all the devices right now in Mexico. For example, Impella 5.5 on RP are not yet available. Hopefully at the end of this year we have them. But we need to integrate what we have into the reality of our practice. So we've been creating workshops and simulate. We have a simulation lab at the med school. We do ECMO simulation and hemodynamic evaluation and integration of data. And I think one of the most important challenges we faced was resistance to change at the beginning. Since we started, there were some colleagues that were like, I mean, we've been treating cardiogenic shock since forever, and I mean, the purpose of making this as a multidisciplinary approach was a bit of a friction at the beginning. There were some resistance, but then when we analyze our data and when we analyzed our survival rates improving, people get motivated. And when we analyze that we're doing more advanced MCS use, more SWANs, and then we observed that there's been an evolution in our program. We have collaborating with different hospitals in Mexico and outside of Mexico. And this is just a brief summary of what has been our shock initiative in Mexico since we started in Monterrey at the end of 2022 until now. And this is actually a paper from our next speaker that actually points what are the blueprint or the protocols to develop, but also to maintain a cardiogenic shock. Just to finalize, I would like to invite everyone to our third annual Shock LATAM Symposium that's taking place this year in October in beautiful Cancun. And with that, I would like to thank you very much for your attention.
Excellent. This is open now to questions, comments. So, David, do you want to go first?
They really, really wonderful. It highlights that the challenges are the same everywhere, whether it's a hospital with 150 beds or 1,000 beds. And congratulate you for moving the care forward for your patients.
So that was really well done, and we all know how much work it took and you just presented the tip of the iceberg. What was the top challenge and how you, from all of the challenges that you faced, what was the top challenge and how did you manage to overcome it?
I think at the beginning to understand, because when we started, the first thing administration looked was the costs. You know, the cost of the ECMO, the cost of the Impella, but it was a big challenge for us, like to push this program at the beginning. Since the administration was like, "This is going to be a very expensive. Nobody is going to be able to get these devices." But to explain to them about the benefit of doing right to. That's why we created a shock team to appropriately select what are the patients that may benefit for these devices. So I think that was at the beginning a really top challenge. The other ones we've been like evolving and we've been gaining experience. Now that people show the outcomes, the improvement on survival rates, people get really motivated. I mean, a patient that normally will die in the ER, now this patient walks out of the hospital, and that really motivates the people. And other institutions from Mexico, I mean, we're a small hospital compared to public hospitals in Mexico, but they are looking at our program, and we started collaborating together in order to improve survival rates. And I think our symposium that this taking place this year is trying to integrate the practice in Latin America in order to improve survival with the capabilities that we have. Somebody has to push for this.
Sometimes it's the mentality, right? Because when you read the story of Ford, they say at that time people were saying we need more faster horses, right? And he came with the car. So exactly. This is the thing that you have to fight there.
Well, let me, along these lines, and it's a little bit, when it comes to political decisions about cost, and you mentioned it nicely, you show the person walking alive out. So the counter-argument from resources utilization and allocation point will be what's the cost of saving one life and the resources versus building more schools or doing other things, right? So when you talk to the financial people and they talk higher, especially if your hospital was in a public or the reimbursements you get from the insurance. So how do you approach these and where are the cutoffs? And that's, I think, one of the reasons that when we hear from other systems, there is also a push right now in our country to rearrange some of these things that we take for granted. So how do you make the cutoffs? And how, when you said to convince them, so what did you use in order to convince them? What was the argument?
I mean, this is a private hospital, so I would say like 70% of our patients have medical insurance that covers, but not all medical insurance are the same. They all not cover the same. I mean, you can get a medical insurance that covers like millions of pesos, but in Mexican pesos, but some others have medical insurance that won't cover for that. So the administration look, well, for example, when we have a patient that collapses at the ER, while we have an eCPR program at our institution. While we're doing the eCPR, some of people from the administration are looking for if the patient has an insurance and what is going to cover for them in order to also take decisions of what's going to come next, because maybe we spend a lot of money in this patient and then what's coming after that. So that's what I mean by this difficulties at the beginning of the development of the program. So we have to really analyze not just the clinical context, but also what can we do with this patient regarding the financial issues.
Thank you.
But
Very
we're
nice.
pushing to it.
I congratulate you on the house that you've built. I think any of us that have owned houses always realize that the hard part is maintaining the house. And I think even in any of these programs, I think most of us realize, you know, ER doctors change, the residents change, the nurses change, the administration, and you've got to keep invigorating or retraining the people in a constant fashion. And I think that's one of the harder parts. You've done the hardest, but then the next part is the maintenance, and that I find is...
Completely agree.
That's great, and actually it's a great segue to the next talk. Thank you so much, that was exceptional. Thank you. This is